All right. Well, for this next period, I'd like to share some information with you about fractures in teeth, complex endodontic diagnosis, longitudinal tooth fractures. And if we can turn these lights out, it would be great. Once again, I do not receive information from companies. This is my disclosure for the presentation. And I actually chose this topic because I love speaking about it. I have talked about fractures all over the United States, all over the world, different parts of the world. And I have a mission to try to have a means by which we can communicate with one another effectively about the different types of cracks and fractures that we come up against. These are very difficult to manage. They're difficult to see. They're difficult to manage. There are many things about them that are myths, so to speak, that I'd like to dispel today. So I use the term longitudinal fractures. Why do you think I might use the term longitudinal? What does longitudinal mean? I see some people going like this versus like this, right? So longitudinal on a map is going up and down on the longitudinal plane. And as a matter of fact, all of these fractures that we're going to, cracks and fractures that we're going to discuss this evening have a vertical component to them, and they could all be called vertical fractures. But there are some characteristics about each of the types that I would like to classify for you so that we can speak globally to one another about these fractures. There's another definition of longitudinal. Some of you have probably been exposed to longitudinal studies. And these are studies that what? Occur over a period of time. So when we combine the two definitions of longitudinal together in relation to cracks in teeth, what we come up with is cracks or fractures in a vertical plane that have occurred over a period of time. Okay? So that is the definition. This term longitudinal was started, I take claim for it, Eric Rivera, and there are some actual classic signs and classic confusion, because I would go to the literature to find out information about cracks in teeth, and lo and behold, I actually found that much of the literature dealt with what we now know is a true vertical root fracture, which is different than a crack in a tooth. And then when I looked up information about vertical root fractures in the literature, I found information about cracks or splits in teeth. And I'm here to show you tonight something that you may have already been taught, I'm not sure, that there is a difference between these types of fractures that occur over time. Also, there's confusion because these fractures many times are very difficult to actually see. Sometimes you have to have specialized equipment, i.e. a flashlight, transilluminator, to be able to see these fractures. How many of you know what a transilluminator is? Do you have transilluminator here in Guatemala City? Oh, I'm costing the dean money here with every word, huh? I hope that you have a transilluminator. I'll go over that a little bit. I think it's important to review just a little bit of literature first. And in looking at the Bader Martin Sugar's article, this is from UNC actually, 95, they talk about the preliminary estimates of the incidence and consequences of tooth fracture in the JADA. Very nice article, but I'm highly critical of it because they have a tendency to lump all of the different types of fractures together to come up with these incidences, and I believe that they need to be separated so that we can learn about each of the epidemiological problems that are associated with these fracture types. There are many different classifications of fracture. For example, Euler is just one of many classification schemes, and which he uses on whether a fracture is complete or incomplete. In other words, there's a crack in the tooth versus one that has split wide open. But that's not enough, in my opinion, to really be able to describe these fractures to one another. So I took it upon myself, along with Dr. Richard Walton at the University of Iowa, and we have actually come up with the absolutely best classification scheme for fractures that is present. So the American Association of Endodontists in 1997 used Dr. Walton and my scheme related to fractures in teeth in talking about the cracked tooth code and their colleagues for excellence. Walton started this idea in his textbook, but we developed the term longitudinal fractures in the second edition, and this is continued now in 2008 with the most recent edition, fourth edition, in the Tor-Benezet and Walton textbook, in which there is I made a mistake. That should be Rivera and Walton. Sorry about that. That's fine. And there's a sample of another article related to cracks in teeth. And the American Association of Endodontists has a new 2003 guide in a pamphlet form. The American Association of Endodontists has a new Cracking the Cracked Tooth Code, Detection and Treatment of Various Longitudinal Tooth Fractures that has come out. And very recently, about a month ago or so, there's another article in Endodontic Topics related to this. And so you can go to any of these articles, especially the last two, for most of the information on cracked teeth, or get these pamphlets from the AAE. This is the Endodontic Topics, in which the focus was mainly to discuss more about diagnosis and how diagnosis is different from detection. And it is my humble opinion, or maybe not so humble, that when we see fractures, that we have not diagnosed anything. We just see a fracture. We have detected that there's a crack or a fracture. That has nothing to do with diagnosis of pulp or periapex. And also, this article was intended to give more information related to what we have to do sometimes with moving segments apart to see if indeed they can be wedged to determine whether there's mobility of the segment. The classification system that I would like for you to use is this: Kray's line, cuspal fracture, cracked tooth, split tooth, and the true vertical root fracture. Now, I took up most of my time going through that scheme to allow you to think about what you visualize when you hear each of those terms. And I'm going to do the same thing at the end to make sure that I hope we have a globalization view, concentric view, that allows us to communicate with one another about what each of these different classification schemes mean. So let's go into each of them individually. In the handout, you will see that we have compared these different classifications with regard to the location, where they are in the crown, the direction of the fracture, orientation, symptoms, signs, how we identify the fracture, the crack or fracture, the treatment, and the prognosis. And you can see graphically here that it's different depending on the classification scheme. They're not all the same. And this is what I want to enhance and show you during this presentation. Now, what I'm not talking about is the BAM type trauma fracture. Here we have a traumatic injury that might occur. And what's the difference between a longitudinal fracture and a fracture as a result of trauma? They still may be vertical, some of them, from the traumatic injury, but the impact is immediate, as opposed to the fracture line that grows with time, with the longitudinal fracture. As a matter of fact, you can use this when discussing with your patients, that you'll probably say to them, have you ever seen a crack in a windshield? What happens with that crack? It propagates or grows, and then sometime it's going to go crash, fracture, and the same thing applies with your tooth. Okay? By definition, is located on the crown. The direction is variable. The orientation is to the occlusal only. There are no signs and symptoms involved. And we can identify these by using transillumination. In other words, take a little flashlight, like you maybe did as a child, to look at your nail bed, to shine through. Well, we do the same thing to look at the differences in light propagation. And I'll show you that. There's no treatment, and the prognosis is excellent for these. There might be some concerns with aesthetics only. So why in the world would Dr. Rivera have this as one of the 5 major classification schemes for fractures? There's nothing here. Well, let me ask you a question. Raise your hand if you do not have a crazed line in your mouth on any of your teeth. No one raised a hand. Why? Because they are so prevalent. It is significant, the number of crazed lines that are out there. And there are some individuals that have stated that a crazed line can be the precipitating factor for a crack in the tooth. Thank goodness that is just not true, because we would have an epidemic on our hands. Who wants to have a cracked tooth versus a crazed line? Anybody want to have a cracked tooth? No. You already know the answers to this lecture, right? So there's another thought process, and that is that for those crazed lines that are present on the marginal ridges of premolar and molar teeth, they may be confused with a crack. And so that's another reason why I do indeed have this as a classification scheme. And I could take anybody's photograph and put it up here to show crazed lines that are present. Now, the cuspal fracture itself is different. For the cuspal fracture, its location is crown to root. The direction is either mesiodistal and or facialingual in orientation. I'll show you a diagram. The orientation is towards the occlusal. The symptoms are usually acute. You probably have seen a patient that comes into your clinic or office and says, gosh, every time I bite down, doc, I feel pain. It's acute pain. That's a red flag right there to look for a crack or a fracture. What do I mean by crack and fracture? I don't do a very good job of distinguishing sometimes, even in the classification scheme. But this is what I think in my mind. And I use a pristine, wonderful, beautiful teacup from England to think about this. Cup of tea. Okay? The teacup can be wonderful, but it might have a little bit of a blemish, like a crazed line that's present. Has nothing to do whatsoever with being able to hold tea, but it probably might not look the way a pristine cup would look. Then there may actually be a crack that's present in the teacup, where if you fill it up, nothing might happen with the tea, or you might begin to see little droplets come through the crack and show themselves as a little droplet area. And that would be a cracked teacup. Whereas if there's a piece of the teacup that's missing because of a fracture of the teacup, if you fill that up with tea, it would overflow significantly. So that's the same kind of thought process I use with teeth in these descriptions. Sometimes I say fracture inappropriately when I mean crack, and vice versa. And even in my diagnosis scheme, I do the same. I'll show you. But for here, what we have is that the symptoms are acute. The signs are that there is a separable segment. That's most of the time. You don't have to have it. This is one area where my scheme falters. And there probably should be something called a cuspal crack versus a cuspal fracture. But that gets too complicated, I believe, and so I've been relegated to leave it as a cuspal fracture as such. How do we identify this? We remove that segment that's fractured. The treatment is the removal of that segment and restore. You would perform root canal treatment if necessary. In other words, if the fractured segment came in contact with the pulp and the pulp was exposed, you would have to perform some type of root canal procedure. And the prognosis is generally good here. And what do we have for cuspal fractures? This is the diagram from the AAE in which we see that there is a mesiodistal component and a facialingual. Mesiodistal and facialingual, usually involving one cusp, but can involve two cusps on the same surface of the tooth. Now, when we look at this, gosh, there is something extremely interesting to me from the proximal view. What do you see that Dr. Rivera thinks is just so outstandingly interesting? What do you see? Is there a filling? There's iatrogenic placement of a filling, a restoration that's present. And as a matter of fact, that restoration is actually what causes many of these teeth to crack or fracture. So I might be guilty many times of saying that you and you and me and you cause these fractures to occur. What's your defense? Well, Dr. Rivera, I had to remove the decay. The last lecture said remove disease and everything heals. So I had to remove the tooth structure, and in doing so, I weakened the tooth. And yes, it did crack, but that's better than the alternative of having the disease that's present. There's one more very interesting thing to me about this slide from the proximal, and that is that the fracture line itself is not centered usually with the cuspal fracture. It's usually off-center, many times in the exact same ending position as the restoration itself. And so what we have here, I'm going to show you some photographs of teeth, and you might think that every single one is going to have a crack. But you've probably learned enough about me from spending this little bit of time to know that I might put something up that doesn't have anything to do with a crack. We'll see. Keep you on your toes here. So, is there anyone in the room that does not see a crack on the distal marginal ridge? Everybody sees that. Now, some of you are very astute, and you probably have seen not only the crack that's on the distal marginal ridge, but you probably saw the crack that is present on the lingual aspect of the tooth as well. Using the system of determining what type of crack or fracture this is, what would you say? Is this a split tooth? No, not likely. Is this a vertical root fracture? Heck no. But some people call these vertical root fractures, and they would be correct because this is a vertical fracture and going down onto the root, so it could be called a vertical root fracture, but not a true vertical root fracture. And how many of you say, I don't know? Raise your hand if you say, I don't know, because you got the right answer. Everybody raise your hand. Yeah, because we don't know. What do we have to do? What do we have to do to be able to determine what type of fracture this is? We have to remove that gorgeous, beautiful restoration placed by that gorgeous, beautiful dentist. When it gets in my hands or in many of my colleagues' hands, it's gone. We have to get rid of it in order to be able to determine the extent and location and the extent of that fracture. And in this case, when we removed the restoration, we did determine that it was a cuspal fracture because it had the mesiodistal and facialingual component associated with it. Cuspal fractures may present also in another way. You can see in the premolar here, one of the premolars, that there's a difference in the opacity of the enamel. If I can point it out, I would point to this area and I would draw the difference, and when I removed it, you might be able to see it a little bit better, that there is a difference in the opacity, and this is an indication that this tooth does indeed have a cuspal fracture. Now, we also have some wonderful techniques to determine whether a tooth has a crack in it, and this is called the tooth sleuth. Is there anyone that hasn't seen the tooth sleuth? Tooth sleuth. Is there a few of you? This is another, chalk up another thing to purchase for the clinic here. A tooth sleuth. They used to give these out at meetings, hand them out freely, and they stopped doing that, of course, to get you hooked to buying them. They're very nice because they're easily sterilizable, readily available, and the forces can be placed on individual cusp tips. And we do so at UNC by using a 3-step method. The first step is to bite lightly on the tooth sleuth. Second is to squeeze tightly, and third is to open quickly. So it's light, squeeze, open. Light, squeeze, open. And if the patient has sensitivity, either on squeezing or opening, that may be a significant sign that there is a crack of that particular cusp. Now, just because they don't say anything, this is one of those myths, if they don't feel anything, that doesn't mean that there's not a fracture, but if they do feel something, you should be suspicious of a fracture. Another device that we use significantly, and remember, I don't get any money for saying this, but this is the best transillumination unit that has been on the market to me. It's called the Photon Kinetic Instruments Transilluminator. Unfortunately, it's no longer available. There's one little part that no longer is able to be made, and so you can't purchase this unless you beat me buying one on eBay. Okay? And what we have here is a situation where the whole unit can be plugged into the electrical outlet. It can be removed so that it's always readily available and charged. This wand here can be removed, and there's a button that you press, and a light beam is emitted from the tip. And you can then be able to see differences. Now, I'm going to show you one patient that has 2 premolars. One premolar probably has a craze line, and the other premolar has a definitive crack. And I want you to see the difference. What you will have to do is turn off all the lights possible in the operatory. Use your mirror for sure. Look in the mirror and shine the light with the transilluminator onto the tooth. And you're looking at the difference between day and night. These are the principles of physics that you learned probably earlier in your high school years here in Guatemala City. That is, if light goes through an object but then meets a space, what happens to that light? Is it refracted or reflected? The answer is kind of both, but most of the light ends up being reflected back so that you have a distinct difference. I call it the difference between day and night, the way it looks on the tooth. So let me show you. Forgive me if I'm... Have you had this before? Okay, thank you. I don't mind then. So I'm going to show you one example here of a tooth that has a transilluminator. The tip is here on the lingual surface, and the light has illuminated through. There's a slight difference here, but most of the light has projected through the tooth. This is in comparison to the next tooth, in which you put the transilluminator into position, and you see that the light is emitted to the point where there's a space, but most of the light is then reflected back. I need to tell you that this photograph was made without flash photography at the same f-stop settings. Same settings. And so you can actually see the difference. It is a difference between day and night in determining which one of these would you rather have, the one on the top or the one on the bottom? The one on the top in your own mouth. So transillumination can be very helpful. You probably will not see most of these cracks or fractures in the teeth without the use of the transilluminator. Uh-oh. What did I just say? This a little earlier, I said that you need to perform vitality testing on which teeth? All of them. What did I just say now? You need to perform transillumination on which teeth? All of them. And unfortunately, when you do, you're going to see more cracks in teeth than you know what to deal with. And you're going to be sad that I ever came into your life. Because we don't know just yet what to do really with most of these cracks. What is the main problem with having a crack in a tooth? What's the real reason? We learned it in the past lecture. What's our number one nemesis? Bacteria. And do the bacteria cause us a problem? Well, if the crack is significant enough that it extends all the way to the pulp, then the bacteria may have significant impact on your diagnosis. So remember earlier I said that seeing a crack is not diagnosing a condition of the tooth. It is only a detection method. You have only detected that there's a crack, but it may indeed have implications on your diagnosis depending on whether the bacteria have been able to come in contact with the pulp or not. Do you see a crack here? Do you see a fracture here? Is Dr. Rivera being tricky? If we look at it from a different way, what you're seeing here is the mirror image of this tooth. We're shining the light, and we only see the light shining on one cusp only. And this is what we're looking at. This is actually the mirror image. This is the real tooth. We're looking in the mirror, and we can see where before we couldn't tell maybe that there was a crack, or this is actually called a what? Cuspal fracture. Interestingly, also, there may be a probing defect. And I would bet you, what we say in the United States, I'd bet you dollars to donuts that you have been taught that there are 6 probing measurements that you write down on your paper for perio. Is that correct? Mesiobuccal, facial, distal buccal, etc. Is that correct? 6 points that you write down? I absolutely disagree with that conceptually. I believe that there must be a thought process that includes 8 points of determination. Now, unfortunately, most of the time, and those 2 additional points are where? Mesial and distal. Most of the time, the tooth structure does not allow you to be able to take a probe and perform a mesial or distal probing of the tooth, unless there's not a tooth next to it. Okay? So most of the time, you cannot get that 7th and 8th points to write down, but that doesn't mean that you should not think about them. And so my suggestion is that you have an 8-point contact system instead of a 6-point system, because the fracture line that extends will allow, if bacteria have been able to get into the fracture and cause bone to do what? What do we say? They fight first, but then the bone moves away. That's an area where a narrow, isolated probing defect can be present. Narrow, isolated. How does that contrast with periodontal probing defects? A person that has periodontal disease, what happens? Probe goes 3, 3, 4, 6, 8, 6, 4, 3. But when there's a fracture of a tooth, what does it look like? 3, 3, 3, 7, 3, 3, 3. Narrow, isolated probing defect, red flag, question on the test, red flag. This would be alerting you that there may be a fracture that's present. So, let's move on to the cracked tooth. The cracked tooth, by definition, is an incomplete fracture initiated from the crown and extending subgingivally, usually directed mesiodistally only, usually mesiodistally only. The fracture may extend through either or both of the marginal ridges and through the proximal surfaces. So what we have by definition here, in comparison with the other cracks and fractures, is that the location is on the crown only or may extend down from the crown onto the root. That's why some of these are called vertical root fractures, inappropriately, I might add, in my mind. The direction is mesiodistal as opposed to mesiodistal and facialingual. Most of these are mesiodistal. And here's another area where my scheme breaks down, because you may, in about 1% of the cases, be able to show me a facialingual fracture facialingual cracked tooth. But it doesn't happen very often at all. The orientation is to the occlusal. Get this, the symptoms are highly variable. Keep that in mind for just a few moments, because it's going to come back to haunt us and we'll have to think about that. The signs are also variable. How do we identify these? We want to remove the restoration. We can perform staining with methylene blue. We can use biting forces. We can use the transillumination like I showed you. You can use a surgical operating microscope or loops to magnify the area, and wedging of the segments. Once you remove a restoration, you can place an instrument to see if indeed the segment will move or not. The treatment is also varied, and the prognosis is questionable. I've given you some prognoses as excellent, good, and now questionable. That's a bunch of baloney. This is just me coming in and giving you my thought process only. Where in the literature has it shown that the prognosis for a cracked tooth is questionable? We call it Bo, Jack, Diddley, Squat, which means nothing. Bo, Jack, Diddley, Squat in the literature. Maybe there's an article or two, one of them by Krell and Rivera, that talk a little bit about prognosis with cracks in teeth. But for the most part, we say that this is questionable. Why? Because we know from my previous description that the crack will do what? Propagate over time. Okay? And we also need to understand that the crack that is present on the tooth, I will hold my hands up like this. And for example, the people on this side of the room will be able to see when there's a force added that the tooth might separate microscopically. Over here now, I'll do it the same way. And what we need to do for those instances is to try to put a covering with full coverage of some type of restoration that will prevent that tooth from moving, to therefore prevent that propagation from occurring. Okay? So, the caricature or diagram from the AAE for the cracked tooth from the proximal point of view looks much different from that of the cuspal fracture. What's different? There's no restoration, and the fracture, or crack, is centered, more centered. Therefore, it could probably be more devastating if it is allowed to continue. If it was off to the side, it might shear off to the side of the tooth. But when it's in the middle and it propagates, it's probably going straight down the root of the tooth. And it involves one or both marginal ridges and maybe involving the crown or the crown onto the root. The problem here is how can you see the extent of these cracks in the mouth? They run mesiodistally, right? So if I was to show you my two fingers right here, this portion of the room, can you tell me if I have one or two fingers up? This part of the room can tell you, right? In other words, am I flipping you all the finger? Or am I giving you the peace sign? Am I a good guy or am I a bad guy? Now, can you tell me whether my fingers are touching one another or not? Okay? So this side gets the same treatment here now, right? Equality here. And you know I'm giving you the peace sign, not the one finger up sign, okay? All right? And so therefore, you can use that with your patients when they ask you, well, why are we making more radiographs? So that we can see things in different ways. Well, the problem with making more radiographs conventionally is that we still can't see very well. We may have some future hope with, have you heard of the CBCT, the cone beam CT scans, where we can get a three-dimensional scan? They may be helpful in the future. Right now, they're probably too expensive, but we have a store called Bed Bath & Beyond. Have you heard of that before? Bed Bath & Beyond. This is my hope that the CBCTs will be available for $999 at Bed Bath & Beyond next week. Okay? In other words, that's not going to happen, but that's the beyond part of Bed Bath & Beyond. Little bit of science here. Hyatt very early showed that teeth with incomplete crown root fractures actually have a good cusp-fossil relationship, and the fracture runs in a mesiodistal direction, as I've told you. Only posterior teeth are involved, and 3/4 of the involved teeth had no proximal restorations, just like in that diagram that I showed you. 71% of the fractures were found in mandibular molars, probably because they're on that hinge axis and get more forces on mastication. Cameron is the person that came up with the term cracked tooth syndrome. How many of you use that term cracked tooth syndrome? Anyone? I absolutely hate that term. I hate it passionately. It is a term that causes so much confusion. I passionately detest the use of cracked tooth syndrome. I love syndromes. There are many syndromes that Dr. Padilla can tell you about over and over again, and those are lovely because they are true syndromes. But there's nothing about a crack in a tooth that relates to a syndrome. As a matter of fact, how many teeth with a crack have a diagnosis of irreversible pulpitis? How many teeth with a crack detected have a diagnosis of necrotic pulp? I don't know. Have no idea. There's no correlation, no relationship whatsoever. So using the term cracked tooth syndrome indicates that usually the thought process is that the patient is sensitive to cold and sensitive to biting. And that makes up the cracked tooth syndrome. But just because a patient is sensitive to cold and biting doesn't mean they even have a crack in their tooth. Number one. So I detest the use of the cracked tooth syndrome. But Cameron found that just like Hyatt, most of the fractures occurred in mandibular molars. 35% of the patients actually had a history of a previous cracked tooth. 25% could make their own diagnosis, maybe because they've had it before. And get this. This is what's so devastating to me as an instructor, because what we preach and teach about the importance of performing vitality testing, right, and making the appropriate angle radiograph, it all falls down, unfortunately, when we talk about cracks in teeth. Pulp testing and radiographic findings often do not contribute to the diagnosis. As a matter of fact, I can answer the question for you. 75% of the cases had a vital response to pulp testing, and 81% of the cases reveal normal radiographic structures. That's what I showed you with my finger. Most of them are in the mesiodistal orientation. We also have Abu Ras talking about the green stick type fracture that occurs commonly in non or minimally restored teeth. And the confusing item here is the craze line that I talked about that may actually involve the marginal ridge. Now, let's look at this tooth. Can everybody see that there are two cracks on the marginal ridge? Correct? How extensive are those cracks? If this was in the mouth, be hard to see. But we can see them here, and I'm going to show you what they look like. One of the cracks extends into the enamel only. The other crack extends all the way into the furcation area. Have you been taught how to manage these yet? You want to remove the crack. Is that correct? But would you remove a crack that extends all the way into the furcation? I hope that you're being taught, no, don't do that, because you're going to make that tooth more prone to fracture. As a matter of fact, you might cause that tooth to fracture. So what I just said there is absolutely horrible, detestable coming out of my mouth. Because what did I just say? A crack which contains bacteria, let's not remove the crack. If it goes down here, let's leave the crack. And this is probably, question? No, this is probably a terrible situation for us to deal with, because we don't know still how significantly affected the pulp is as a result of the bacteria, the bacterial contamination. Okay, this is what I was talking about, a syndrome. Syndrome is a group of signs and symptoms that characterize and specify a particular abnormality. A snidrome, I hate it so much, I kept it in the first time I gave this lecture, and I've kept it forever. Set of concurrent and repeatable things that form a distinct identifiable pattern. We don't have any of those things with a cracked tooth. So let's defeat that cracked tooth syndrome enemy, please. Now I have a series of cases that I'm going to show you that will show you different extents of the crack. Here we have a situation where there's a dental student having a problem. We can't really see in this tooth. There's a minimal to moderate size restoration, no periapical pathosis. The tooth is responding to vitality testing. We can transilluminate, and in this lighting we can't see it, but there is a distinct difference between the cusp on the buccal versus the lingual. We can remove that restoration, and lo and behold, we see that there is indeed a crack line. This crack line has been discolored. Why? Because of the corrosion products by the amalgam. So we know that it's been there for a while. And we can see that it's on the marginal ridge. So it's on the marginal ridge and along the proximal surface, internal surface. That's how we would write it down. But notice it is not along the access cavity floor. We don't call that the pulpal floor as in your textbook. That's actually the cavity floor, not the pulpal floor. And so here, with our findings of there being a responsive pulp, no periapical pathosis, we elected to perform a crown. Now, does this tooth have a crack in it on this marginal ridge here, mesial marginal ridge? I can't see one. Is this a cracked tooth? If I can't see it, is this a cracked tooth? What do I need to do? Pull out my what? Transilluminator. And I'm going to overlay another slide that will show you, with the use of transillumination, that there is indeed a difference between night and day here. As a matter of fact, if we do it from the opposite side, we see the same configuration here. So is this a cracked tooth? Even with magnification, if you did not have the transillumination, you probably would not be able to see that this tooth is indeed cracked. This patient happened to be symptomatic. They actually had symptoms to cold and sensitivity to biting, i.e. cracked tooth syndrome. So you that said cracked tooth syndrome would have gotten it right. It just so happens this time. But it's really just cracked tooth only as a detectable sign. The diagnosis is different. And even with big magnification, we might not be able to see that. So once again, transillumination may be the way to go here. Now, this is a case in which we see that there are two cuspal fractures already, and if we remove this restoration and look and remove the bubble here from the water, we see that there is a crack in the tooth, and there's an apical periodontitis that's present. And in this particular case, once the restoration is removed, we can see that indeed there is a crack that's going across the tooth on the floor of the cavity preparation. Our prognosis just decreased significantly, more than likely, but I can't support that from information from the literature. And a stainless steel crown was placed in that situation. I've seen this significantly here now. Not significantly, but more often than I thought. Initially when I saw this, I thought it was just a stain, but this is indeed a crack of the restoration, the IRM temporary. You probably should criticize me for not removing the amalgam restoration on the mesial because it even has a crack in it itself, but we were able to actually see that there's a crack on the floor on the mesial. Definitely one here on the distal. Once we remove more of the the IRM, we can see the fracture here and here, but I was not able to see a crack on the floor of the pulp chamber. The floor of the pulp chamber. We did locate the fourth mesiolingual canal. You know that's present how often? Over 90%. There's a fourth mesiolingual canal, or mesiobuccal, MB2, present. And when the patient came back, unfortunately, this is what it looked like. We know that this is now a cracked tooth, split tooth, vertical root fracture. This would be a split tooth, unfortunately. Whether this would have occurred or not, it seems likely to me, if there's a crack on both sides, that there might be a crack in the middle, so that this might be a situation in which you might consider removal of the tooth structure and placement of an implant, possibly, rather than root canal treatment. That's up for debate right now in our association. Notice that the periodontal probing, remember, if there's a narrow, isolated probing defect, that's a red flag for crack in a tooth. And we also know that the probing level defect will go at least to the point where there's a fracture. The fracture may extend even further, but we at least know that the fracture extends that far in the tooth. This tooth was extracted, and you can see with methylene blue that extended well into the furcation area. With magnification, we can see some of these fractures that go into the orifice itself, and we're more questioning whether or not there would be a good prognosis for these teeth or not. We just don't know from the literature. And I've already told you about the tooth sleuth and its use. These can be used in split teeth and other types of fractures as well. So the treatment is to make sure that you perform root canal treatment if necessary, try to prevent progression of the crack, perform endodontic and periodontal procedures as needed. Dentin and enamel bonding with adhesive resins, if placed with special techniques, may reinforce the weakened tooth structure and provide cuspal coverage. We're finding some literature now to support this idea. Also, I have now started stating that potentially, with the use of the type of filling material that you use, if you're bonding inside the canal space, the literature is not very good with regard to looking at the strength, potential for root strengthening. I disagree with that because we're only comparing it with gutta percha. So both of them are terrible, really. When we're comparing it with gutta percha, it's better than gutta percha, but clinically, that's so what? It's still not providing strength in the root canal system, but may be helpful. So we want to prevent split teeth and cracked teeth from happening. And this study that I referred to a little earlier was a study in which it was determined, how many patients have cracks in their teeth in your population in Guatemala City? I don't know. In this study, the number was determined to be out of 6,000 patients evaluated, 10% of them had cracks involving one or both marginal ridges. And of those, we looked at a subset that were diagnosed as reversible pulpitis with a crack, and we referred those back to the general dentist to place a crown restoration. And what we found is that 20% of those patients that were determined to have a reversible pulpitis ended up needing root canal treatment because of conversion from reversible pulpitis to irreversible pulpitis in a short period of time, or necrotic pulp in another short period of time. So this is about all that I'm aware of in the literature, maybe one other article, whereby we are getting some information on the prognosis of cracked teeth. And right now, if there's a reversible pulpitis, you have an 80% chance of not needing root canal treatment based on the evidence from this one particular study. A split tooth now is about the same as the cracked tooth, except now, what do we have? We have a, what? Separable segment. So a cracked tooth actually can very readily turn into a split tooth. And this is what we're talking about graphically here with the split tooth, the newer description. And these are just some examples. This is a tooth that was put together that was split, and you can see how difficult it might be to see the fracture line on the floor. So let's summarize to this point. We've looked at cusp fractures, which are more iatrogenically caused most of the time. There is a restoration, a large restoration. The fracture line is off-center, as compared to the cracked tooth, where there's minimal restoration or no restoration involving one or both marginal ridges, and the crack is more centered. And now the split tooth, which is a further propagation of the cracked tooth, so that now you have separable segment. Let's move forward and look at the vertical root fracture. And I sometimes refer to this as the true vertical root fracture. What we see here is that this is a totally, absolutely, totally different animal, different beast. It is the only one in which what has happened? The location is on the root only. All of the others involve the crown or the crown going onto the root. This one is root only. The direction is facialingual. The orientation is on the root at any level. There are usually no symptoms associated with it. The signs are variable. We can identify these by reflecting a flap and looking to see with transillumination if there's a fracture. The treatment is the removal of that root, and the prognosis for that root is hopeless. We don't have anything in the literature that can be used predictably to treat these vertical root fractures. And this is what we're talking about. There's a fracture of the root only involving one or both facial and lingual surfaces. And this is what it looks like once we reflect the flap and we see a V-shaped type orientation. This is the flap reflected. We can see that there's a fracture here. And why do we see the V shape? Because of the bacteria. The bone is trying to move away from the bacteria that are present here. So, test question. Everybody get out a sheet of... Oh, I'm not in UNC. You don't have to have a test question right now. But what is the direction of the fracture? Facial-lingual. It's been identified in the research as well. And keep in mind that you may have a narrow, isolated probing defect present, but the fracture might not have grown significantly enough to be able to see or feel that probing defect. Which one of these teeth definitely has a vertical root fracture? Which one would you guess? It absolutely would be the one that has had iatrogenic treatment. In other words, from the literature, it is the one that has either had root canal condensation forces. You know, do you use finger pluggers or hand pluggers? Finger pluggers to cause a fracture, or you have a post that has exerted pressure on the tooth to create these vertical root fractures. So the only vertical root fracture I've seen in North America, the only one is related to what? A root canal or a post in the tooth. As you can see here with the flap reflected and here with the fracture line visible. What's inside these cracks, lines, and fractures is mainly food debris, bacteria, etc. There is a special population, a study by Yang et al., that has shown in a peasant Chinese population that there can be fractures present, vertical root fractures identified radiographically and confirmed clinically that have a vertical root fracture without having root canal treatment or post placement. So I encourage you, if you have this situation here in Central America, please let me know about it. You'll go down in history. I'll do all the work for you. Just give me the data, please. We have gone through a process of looking at Kray's lines. Remember, I told you I was going to do this so that we all have the same idea. Cuspal fractures, cracked teeth, split teeth, and the true vertical root fracture. And I'm hoping that we all can use this in communicating with one another to let us know what these different types of fractures are actually.